Thanks very much for inviting me. My name is David Caldicott. I'm an emergency doctor, and I work at Nevill Hall Hospital. Preface all of my comments today by saying I'm not sure how this talk's going to go. I've got pharyngitis. I could stop speaking halfway through this, and then I will have to finish the talk through the medium of interpretive dance. Or alternatively, the super therapeutic quantities of decongestants I've consumed will result in some sort of psychotic break, and you can come to my rescue. So, having said that, let's see how we go. So I'm going to chat to you about new psychoactive substances and early warning systems. At least that's what I've been told to chat to you about. I'll chat about that. I'll chat some other things as well. This is where I've come from today, Nevill Hall Hospital. This was the scene yesterday, about 4 feet snow. It's really cold up there. You guys don't know how easy he got it down here. Those of you who sort of read anything or have anything to do with illicit drugs whatsoever could be, I suppose, excused for thinking that what we're seeing at the moment, apart from the bread and butter of cannabis, heroin, cocaine, it resembles more of a candy store than it does a sort of an illicit drug parlor. There's a weird new bunch of drugs emerging on the street, rapidly cycling. And it's really difficult for us to keep track as physicians, never mind as community drug workers, of just what people are putting up their nose or up their bottoms. And this is merely a sample of the various things that we've seen in this country. And I put it to you that if you can't measure what the subject of interest is for you, you can't manage it. If you don't know what you're dealing with, how much you're dealing of it, there's no way that you can apply a policy to manage it. And that's what our little project is about. It is about measuring the impact of these novel psychoactive products on the community. I'm going to talk a bit about, and I apologize, I know it's the afternoon, this is deathly dull stuff, but it's important that you understand where we come from. This business of drug information systems. These are sort of kicked off, I suppose, as early as the 1960s, but really in the 1980s and 1990s, whereby these are systems in place for formally monitoring how much drug is being used, who's using it, how they're using it. So it's systematically collecting information on the way people use drugs. I'm going to reference three, which I think are probably the biggest in the world at the moment: DAWN, the IDRS, and the MCDDA. Each of which has got different methodologies and therefore different strengths and weaknesses, all of which were designed with different purposes in mind, and probably all of which were designed with drugs that are different to the ones which are currently being consumed in mind. And what's happened, unfortunately, is that the systems and the manners in which people take drugs have outstripped the systems that are in place to monitor the way people are taking those substances. And I would suggest very politely, especially to those of you who are involved in any of these systems of monitoring, that they may not, in fact, be fit for purpose for the current way people are taking drugs. With the caveat, of course, that they're very good to keep an eye on our old favorites, like heroin, the amphetamines, cocaine. They're not bad at that at all. But the newer drugs and the way they cycle, it's probably not the right way to look at them. The Drug Abuse Warning Network is based in the United States. The thing I like about it, it looks at harm. So what it does is it retrospectively looks at emergency department notes in a number of key identified departments, does a very sophisticated statistical analysis and extrapolates it to the global position in the United States. So these sentinel monitoring hospitals, they go through all the notes, they look for any reference of any drug, and that's a ping if you have that. To start with, there was an awful lot of political influence here, so any reference of anyone using any drug at all ever in their life was a ping. It's become a little bit more sophisticated than that, and so now they're just monitoring the presentations to emergency departments, which are directly caused by illicit drugs. However, this is entirely dependent upon the doctor's documentation and, of course, whether a patient chooses to discuss their drug use with the doctor. Believe me, they often don't. I think you guys probably have much more success in the community but with people coming to you directly to chat about their drug use than people coming to us I mean, we're one step down from the cops, really. The illicit drug reporting system is based in Australia and has 3 components to it. Interviews with people who inject drugs, interviews with key experts, I was on that for 10 years, and analysis and examination of this key indicator source data, so the prices of sales, the availability, but once again, largely the big categories of drugs. So heroin, methamphetamine over there, and it's not as big a problem here as it is over there, cocaine and cannabis. It was designed to be very sensitive to trends and turn around quite quickly. So its turnaround is much faster than, say, Dawn. If you check the Dawn website now, the results of 2009 are now available. It's very, very interesting. From a historical perspective, if I'm an archaeologist, yeah, fabulous. But if I'm sort of a cutting-edge acute physician like I want to be, that's gone. That's passé. Couldn't care less about what happened in 2009. The IDRS reports yearly, which is slightly better. That's good. And does state and federal reports. But once again, now, yearly, it's not fast enough. And finally, my favorite, I'm a proudly European person, but the CDDA is a decentralized European agency established in the early 90s, long before any of these sort of drugs were known. So they're really quite clairvoyant. And what they do is they centrally collate all of the data that is collected in the member states and put together reports as and when they're required. There's an annual report, but also they can put together special reports very quickly, which is impressive. So, you know, if something new and hard and nasty and dangerous comes out, we'll usually hear about it within months. And that's getting much better. But still, probably not quick enough for me to do anything or to anticipate what I'm going to do with my patients when they present with some bizarre presentation in my emergency department. There are some problems which are intrinsic, and I would, you know, put my hand in the air and say, yeah, I'm talking about health. You know, I realize there are social problems and everything associated with drug use. My interest is in the health problems. The problems with these particular drugs is that a lot of people, I mean, pitch up and they could call it, well, like take for example Mephedrone. They were calling it Mephedrone. You know, there were about 5 or 6 different names for this product as it came out onto the market. Even the consumers weren't sure what they had purchased and were consuming. I don't know if any of you tried to use ICD-10 for coding for drug use. It's just crap. Even if you could find out what the drug was, you'd have no way of systematically collating that data. There are no chemical standards for these novel products as they come through. So we can't run a test to compare what's on the market because we have nothing in the back of the lab to compare it to. And we have no idea how these products are metabolized, so we can't test their wee-wee because we don't know what we're looking for. These are all drug-related problems as well. You know, how do we code for this? This is what happens when you have a close interaction between methamphetamine and a samurai sword. You know, these all, I think, should be coded as drug-related violence. This is an impact of drug. It's not just toxicological, but how do you incorporate that into a recording system if the primary presentation isn't to do with drugs? So when patients are discharged from hospital, this patient will be discharged, for example, with an eye injury and no reference to the fact that he was battling in his own mind with a ninja warrior. There'll be nothing to do with drug-induced psychosis on his discharge. Similarly, there'll be, for the psychosocial type admissions, occasionally somebody who's got their head screwed on will put down something to do with the drug-induced psychosis. But a lot of times, a patient who presents like this will be just chalked down as a psychotic patient rather than any reference to the etiology of their psychosis. This is a vascular problem, but it's a vascular problem caused by shooting up heroin and hitting an artery rather than hitting a vein. So all of these things are, you know, this is back to our bread and butter drug use, but we're not capturing this information in the way that we really should. This is interesting. I hadn't seen this before, and I don't know if any of you guys have. This is from fairly heavy-duty Mephedrone use, there's erosion of the soft palate. I don't know if you can see that all right. Does that project okay? You can see that there's just a hole in the soft palate there, which, now that you know what the Mephedrone is and how it works and that it's a vasoconstrictor, it shouldn't be of any surprise to us. It's exactly the same as cocaine. You get this as cocaine use as well. But these are sort of patterns that we can and should be looking for, but we aren't capturing this data anywhere. Just to go through a few more. Haemorrhagic cystitis associated with methoxetamine. I think that's going to be the next thing. The ketamine bladder, I think a lot of you would know about already. Methoxetamine is, well, frankly, almost a structural analog of ketamine, and I'd be very surprised if we don't see this in association with methoxetamine use. It's an aryl cyclohexamine. People don't know that cannabis causes heart attacks in some people. So what I want to find out, purely from personal curiosity really, is what are the substances that people are using? Who is using them and why? So what group of people use them and what sort of kicks do they get when they use them? And really, are they that harmful? You know, I think it's very easy to go down the Daily Mail route and just go, oh, it's bloody awful. But I think a lot of the novel products that come through are probably just not very good as psychoactive drugs. And you know, they're just harmless but useless from a drug consumer's perspective. So we should really allow ourselves a little bit of step back and rationalization about, is this as dangerous as people think it is? We started this sort of approach in Australia a while back now, when we sort of participated with the rave communities and took all their pills and tested them there. And we've been very fortunate in the support that we've had from the powers that be here to be allowed to participate in this project. We call it WEDINOS. The GOGs among you will know that that means after dark. It's an abbreviation for the Welsh Emergency Department Investigation of Novel Substances Group. And so I'd like to chat to you a little bit about this, because I think this addresses some of the shortcomings of the monitoring systems that we were talking about earlier on. And I think the information that we get from it may be of interest to you guys. You'll know that it's really important for you when you engage with consumers to be credible, to know what you're talking about, and to have really up-to-date information. The new generation of consumers reads books, works online. They read scientific articles. They want to know precisely what's happening to them. And they can't be persuaded to stop doing something if they're given a rational reason why. So we describe 3 tiers of investigation with WEDINOS. We identify the products that are associated with harm. And I think that's really important. This isn't just some sort of shotgun, let's just take everything we find and investigate it. By definition, this is harm minimization. People who come to the emergency department under the influence of these substances are harmed. So this is a really clever and good way to identify products that are causing harm. And I think that it's much more important, if you were to choose to give me a patient with a novel set of symptoms or a drug, I would probably prefer to take the drug and obviously analyze it rather than consume it. Because I think I could probably work out a lot more about what that drug was going to do for more people, about its purity, about its function, about its structure, than just looking at, say, for example, somebody with a vague selection of symptoms. They're very frequently similar at different doses, and then they diverge. If you look at, say, for example, a venlafaxine overdose, this is something that has got elements of a tricyclic overdose, elements of a serotonergic overdose, and a lot of these illicit substances are exactly the same. So I can predict a lot more from the product than I can from the overdosed person. Having said that, it's very useful for me to be able to marry that analytical data to the patient and to be able to say, this is what we know that this person has got in their system, and this is what physiologically it has done to them. We can also identify patterns of harm, and I'll show you how we can do that. And what I'd like to do, what I think the future is maybe with the assistance of far more experienced people like yourselves, is to develop brief acute interventions in the emergency department so that people can be engaged within the emergency department in a rather sinister way, I admit, when they're vulnerable. And that's what I'd like to do. I don't know. Yeah, that's okay, yeah. So this is the ultimate goal, is to have a series of monitoring hubs across Wales, based in the emergency departments. At the moment, we're running a pilot in South Wales, but I'd like to have a distribution network all the way through Wales, because patterns differ, even within a small country as well, such as Wales, as you know. We've been busy taking drugs off people and analyzing them, and you might think, oh goodness, that they're not going to cooperate or collaborate with you when you do that. That's not true at all. A lot of the time, people are really quite desperate to find out what they've consumed. Having consumed it, it seems to be a little bit ironic, but they really want to know why they were sick, because obviously they've been sold stuff which they've been told is completely safe. It's a legal high, and therefore it must be safe. That is a very powerful level of engagement for us, because we can give them information that they can't even find on their own bulletin boards. So if you look at a lot of the legal high bulletin boards, it's all, well, I think it might be this, it could be a cathinone, and we can pitch up on their bulletin board and say, do you know what, this is exactly what it is. We do that through our good colleagues and friends at Landock Hospital using GCMS, and also through our colleagues in Cardiff. So basically what happens is the punter turns up with a product in their possession, and they're unwell. And we say, well, do you know what? I can tell you what that is if you want. They say, oh, I know what it is, mate. It's Jolly Green Giants. They say, well, but do you know what the chemical is? They said, nah, nobody does. Well, no, we can tell you what that is. And they are engaged. They're intrigued. Obviously, we have to do this with their confidentiality secure, and that's paramount. So at no stage do patient information or patient confidential details get distributed anywhere. We have a logbook in our controlled drugs cupboard, which corresponds to a unique study number, and that unique study number is affixed to the product, which is then transported to Landock for analysis. If it matches anything that we have in our bank, then we know what it is. If it doesn't, it gets passed on to our friends at the University of Wales School of Pharmacy, and they put it through their nuclear collider or whatever it is, their NMR machine, and work out the precise structure of it. So, for example, we were the first people to know exactly what methoxetamine was. That first analysis prior to any publication was done in Wales. We've also had a look at the MSJs, which I'm sure you all know by now, are diazepam, but I think we're some of the first to confirm that's the case. I mentioned methoxetamine, and also the Energy 2, which we identified under unusual circumstances involving a TV production, and that's 4-methylmethcathinone. So this is not without its precedent, but what is without precedent is a systematic way. We, in Australia, were analysing bits and pieces here and there that might have been interesting. But what we've been able to do with the encouragement of the Welsh Assembly Government Public Health Group is to do this systematically. And that's amazing, because nobody else is doing that. It's so amazing that we've managed now to engage our European counterparts, who are very interested in the sort of data we're turning out. So the idea is to have an emergency department amnesty bin. This is methadone, which is something that we saw a long time ago in drug sense, 2004. And when it first came out in Australia in 2004, a lot of us felt this could be where we're going, because this was being marketed as a legal high. And my own feeling is this is probably the first. Yeah, I don't know if you can see that. It was marketed as ease, sort of like play on words for ecstasy. We also were able to identify the neo-organic products, which in fact were the first ones to contain mephedrone. The other thing we can do is, I don't want to sort of, sometimes it's useful to overplay your importance when things political, but I would draw your attention to this graph. When you look at the difference between the illicit drugs and, say, for example, alcohol. okay? This is in our health district, hospital presentation. So we're looking at all, because it could be any drug that we just choose to put our eye on, but this is for Mephedrone. And this is for all presentations within the Abergavenny Health Board. And it looks pretty dramatic. Yeah? And so if you look at the axis on the left-hand side, we're getting a fair few through. But if you compare it to alcohol, okay, the alcohol is overwhelmingly the most important drug for us in the emergency department. So while it's very cool and trendy to be into the legal highs, and I think it's important to keep tabs on them, those of you who are doing day-to-day work on alcohol are probably serving the community in a far better way than freaks like myself who are doing their philately and stamp collecting with the much more rare and exotic legal highs. And interestingly, this is the same thing everywhere in the world, forever. Alcohol, this is from work we did in Australia 10 years ago now. It's the same. Alcohol remains by far and away the most important drug. The legal highs are fascinating and curious, and they're like little butterflies that need to be caught and identified quickly before they hurt people. But the sheer volume of people hurt by alcohol overwhelms not just the legal highs, but this is against all other drugs, everything, heroin, cannabis, cocaine, all other drugs. And that's the same all the time, everywhere, all over the world. I read an interesting paper, and this is, once again, there's no point in trying to manage something if you can't measure it. And this is an interesting paper from Wood et al., suggesting that the legislation regarding Mephedrone has actually stopped Mephedrone in the community. And we were astonished by this, because that certainly wasn't our experience. This is our experience. There's ongoing use. Welsh people are dead keen on their drugs, and they're not going to be bothered by something as simple as the law. But I think it's important, if you're going to introduce drugs policy, if you're going to legislate about these things, you need to show an effect. And that effect is sometimes showing that fewer people are getting hurt by the drug. And I don't think that legislation did a great deal to the availability of Mephedrone. So much was bought up prior. There was such a long period of time. Quick, get your Mephedrone now. It's going to be illegal in 3 months. It's ridiculous. So, what's happened there? Well, I apologize for that. That's a very small diagram. I'm not sure why that's projecting like that. But if you look very carefully, it's actually a map of South Wales. And another thing that we can do with the data that we're generating is do postcode analysis of where people are coming from, where they live, when they present with the Mephedrone overdose, for Mephedrone. And we were interested, that the distribution, the demographic distribution, was quite different to a lot of drug use, and that it seemed to be associated with areas that are of a higher socioeconomic background. So the assumptions that you can make that, for example, drug use is the domain of the unemployed and the financially destitute is rubbish. But we can show that quite nicely, albeit in minuscule scale. And then finally, we've been very privileged or honored to be asked to get involved, and I think largely as a consequence of our WEDINOS project, in this European-funded project, which is the screening and brief intervention and referral to treatment of adults presenting to the emergency department. And once again, acknowledging what young people are interested in, what we've done is set up a computerized program based around an iPad, which asks the person presenting a couple of questions about their consumption patterns. They get risk assessed and streamed according to what their consumption patterns are like. They provide us with their email address, and by the time they're discharged, they have an email waiting for them so that they can engage with people online if they want to. That email will bring them to a site where they can calculate how much they would spend a year, for example, if they were to continue this use over a year, the potential, the probabilities of individual types of harm that they could come to. It's not judgmental, but it is based a lot around medicine and scientific evaluation. So this is currently being piloted. But I think there's no reason why this sort of thing couldn't or shouldn't be used in emergency departments around Wales. So this is prime time for us as people who care for people to intervene. We do it with alcohol. There's no reason why we can't do it with drugs. I think one of the things about, we chatted about this at the Club Health Conference in Czechoslovakia in December, that it's really important not to try to put what we think is dead cool on our marketing material and how we engage people. And I know that a lot of you are very good at sort of trend seeking. Because if we can virally infiltrate this community's trend set, we can influence them. So people who I've chatted to now are using these. Does anybody know what that sort of squiggly thing is? It's a QR code. So what you can do is you can scan that into your smartphone and it will take you to so you just hold it up and it'll take you to a website. The people who are too wasted to engage in our wedding or in our Asbertes program will be given a little concert wristband so that they can, when they leave the hospital, they can go, God, I was wasted. Maybe I should look into this. And I think, in the same way that we've used Twitter for disaster monitoring in Haiti, we could certainly use Twitter to look at a series of inadvertent overdoses or health problems. So these modern sort of technologies are the way I believe we should be engaging this group of modern users. That, I don't know if it works, but that actually, the QR code should spell WEDINOS. We don't have a website yet, but it will lead to one. So I should probably, you guys are probably falling asleep. I should probably finish up. Where do the dangers lie from these newer drugs? Well, I don't actually think that they're as bad as everybody says they are. They're no better or worse than ones that we've seen in the past. And they're much less common globally. I think the thing that scares the bejesus out of all of us is the rate at which they're mutating. The turnaround time for novel products as they come onto the market is something that I've never seen before and none of my colleagues have ever seen before. It's like having a little flask where somebody's doing an evolutionary experiment in it. And every now and again, when people churn through drugs quickly that way, you come across a real killer. So I'll give you paramethoxyamphetamine as an example. There's an emergence of PMMA in Europe at the moment, which is closely related, or MPTP, the metabolites of which rendered all of the consumers Parkinsonian. So these are the things. It's not the day-to-day legal highs that come through. It's the oddity that I want to be aware of. And by monitoring these, as we would monitor, say, for example, SARS or avian flu, which is just stolen, completely copied the methodology that people use for biosurveillance, and for the first time applied it to illicit drugs. It's absolutely plagiarism. What about the future of this field? Well, it's not great, I'm afraid. People are a little depressed at the moment in terms of the resources that are available to execute these sort of projects. I think enlightened politicians will see the value of this, not just now, but in years to come. The overlap between this sort of project and what it can contribute to other aspects, for example, law enforcement, healthcare, community drug work, is massive. When with a minimum investment in infrastructure, you can really get tremendous rewards. The problem as well is that the world in which we live is one in which more people are going to use more drugs. It's depressing, not knowing whether you're going to be able to afford your mortgage, there is a greater increase in the incidence of depression. Lancet has already reported the increase in depression and illicit drug use in Greece. And as more and more countries feel under the pump for financial reasons, people are going to not only turn to drugs, but also find themselves in positions where the actual systems which will help them have been cut, and there's no way to respond. So it's kind of depressing. I think balancing that, I get a real sense at the moment that there is a bit of a shift in global realpolitik on drugs. So people are now talking a lot more about harm minimization versus prohibition. This is something that's coming through a lot of the UN ODC stuff. The Americans now are engaging a lot more. So there is potentially an opportunity for pragmatic projects. So this is a very practical, pragmatic project to be pushed forward as an example of how we can reduce harm. I think we probably need to make sure that we are covering drug information systems which are addressing these new products, because I don't think that the systems that have been in place for forever do these new drugs justice. And so with a certain amount of very minor tweaking, we can design new systems to identify these new products as they come online. So I've got 2 small children under the age of 2 who love this book, and I would invite you to come with me on a novel psychotropic substance hunt. If any of you are dealing with products that you don't know about, that you want more information about, come to me. I can help you find out what they are. I'd be delighted to engage with anybody. It's a very broad runway for collaboration. At the moment, we're looking at just going through emergency departments. What I'd like to see is maybe involving GPs and also certain key individuals associated with each of the drug agencies who can also in turn submit product into the system for analysis. To be honest, it's not beyond the bounds of possibility for Wales to have one of the best drug monitoring systems in the world. And I'm not one for exaggeration, but I truly think that that is possible with a certain amount of collaboration. And, well, guess what? It was the first. We managed to get through this. I haven't had to dance for you or collapsed from some drug-related problem. I need to thank some people, the people who work with us in the collaboration, the people who do our data and our stats. I'd really like to thank the WAG public health people. I've worked all over the world, and generally speaking, the response we get for these sort of projects is, brilliant idea, politically can't do it, man. And here, they've been really receptive, and kudos to them for picking up on it. And also, finally, to the Daily Mail for helping me maintain the rage. Thank you very much. I'm happy to chat.
Right, if I could just make a very small but important announcement. I've been working with David for a while, with a number of colleagues from University of Cardiff. Sorry, no. And I'm very, very pleased to announce that I was advised earlier today by Welsh Government that the Minister has approved the proposal and we have full funding for rolling out this project across Wales.
You kept that secret, didn't you? Yeah, very tricky. Very.